How you doing? This is Felix Marquez from Orlando Medical Institute. I'm here with some guests to have a discussion on today's podcast. I have Dr. Benzing. I also have our medical directors, everybody's aware of, Dr. Ayanna Walker. And then back with us, Dr. Roca, did another great presentation. So did Dr. Walker. Appreciate you guys coming out and having this discussion with us and doing these two podcasts. As you all saw, Dr. Walker did a presentation on the cell injury, and Dr. Roca did a great presentation also on shock. So we're going to go have a little discussion now. I figured myself, come out, talk from a paramedic's perspective. I hope I represent you guys pretty well, and then we can see the doctor's perspectives when it comes to this. So Dr. Walker, great job on the cell injury, but you talked about the cell itself and all the organelles inside the cell, but are there any key organelles that, as a paramedic, I should focus on? Because maybe down the line in medic school, it'll come back either to haunt me or come back to say, man, I'm glad we talked about
I listened to that podcast. In reviewing the topic myself, and Dr. Crane did a fabulous job on giving this presentation as well. But I would say out of all of those organelles that I remember, I don't remember the smooth endoplasmic reticulum, things like that. But absolutely, the mitochondria is going to time and time come back again, because that's the powerhouse of the cell. It's where you make your ATP. That's where that electron transport chain is. So key diseases I can think about that really, really matter for those are cyanide. So as firefighters, you guys are going to always be in houses where there's smoke. So cyanide and carbon monoxide. Those absolutely affect the mitochondria. It's going to affect that carbon monoxide. Carbon monoxide is going to affect like your affinity for oxygen. Cyanide is going to affect that chain as well. So you're not going to be able to produce that energy that you need. So that is where the organelles will come back, specifically for the mitochondria.
So talking about energy of the mitochondria, and that energy, obviously the two major components, if I'm not mistaken, is glucose and oxygen. With those two, it converts approximately to about 30 molecules of ATP in the cell, give or take a molecule or two. Mm-hmm. So, which is very important to say that, because without glucose or oxygen, we're going to struggle.
Exactly.
As you mentioned. So, is it safe to say that the musculoskeletal system, those cells, use approximately 6 molecules of oxygen to approximately 1 molecule of glucose?
Yeah.
And then the heart is slightly different, right? That's why I call it cardiac muscle, its own muscle itself,
Mm-hmm. Yeah.
It's like, myself, they say I'm kind of different than everybody else. So I'm like cardiac cells. Well, at least my kids think so.
Right. Because you're taking up more oxygen in the room?
I'm taking more oxygen. Yeah, exactly. So the heart consumes a lot more oxygen. So we talk about the musculoskeletal system uses 6 molecules of oxygen to every glucose. The heart uses 17 to 1. Is that correct?
Yeah.
But instead of using glucose, which is pretty ironic, when I did a little research and looking into it, I was like, wow, it doesn't even use glucose. Only small kids would. It uses actually fatty acids. So the key thing I try to tell my students and tell these paramedics, don't get hung up on the numbers so much. Mm-hmm. Get hung up on how much one cell, such as cardiac cell, could consume so much oxygen. Right. So that's why they say all these books you read and all the evidence-based medicine, they talk about, myocardial ischemia sets in within 1 minute, and that's because it consumes.
Versus cerebral, right?
Versus, very good, very good.
You get 5 minutes till you start to see to cell death in the brain.
Yeah.
And partly that's very good because it illustrates kind of what the body's priorities are. Where the heart muscle uses more oxygen because it's pretty integral to keeping everything going. Mm-hmm. So that's where the body puts the energy, because that's what's consuming the most and is the biggest priority for the body itself.
I don't want to cut into Dr. Roca's presentation. We talk about shock,
but I think this is a very good transition into shock, because if you just keep your key points intact, which is the heart and the brain are your vital organs, that's what's happening during the initial stage of shock. Right. The body is trying to perfuse the most important organs, your heart and the brain, and that's how you start seeing the initial symptoms.
What are the first symptoms you see? Altered mental status, the brain.
It's funny, I say, you talked about cardiac output, stroke volume. Mm-hmm. I like to call that cardiac output times PVR equals blood pressure, right? Mm-hmm. I tell my students that's the formula of life.
Yep.
Without cardiac output, without PVR, you have no blood pressure. Without no pressure, you have a dead patient, right? Mm-hmm. So I say nobody dies from a gunshot wound, nobody dies from a heart attack, nobody dies from a stroke, nobody dies from a broken heart.
Right.
But everybody dies from hypoperfusion
Right.
from shock, right? So, and that's the formula. So if you have good cardiac output, good PVR, you have good blood pressure, we know we got perfusion.
Yeah.
Right?
Right.
So you can see right there, it goes to show you how cellular injury ties into shock.
Yeah.
You know, so great point. So you talked about the tissues, the different types of tissues that are in there. I know, Doc, you had something you wanted to add into that when it comes to different
we're
tissues.
mentioning the mitochondria and kind of the basics all tie in and interrelate with each other. Because we're talking about mitochondria, this is also very relevant for something like electrolyte disturbances. We're talking about energy, cellular respiration, phosphate. It's kind of the electrolyte that gets forgotten. What is the AT and P is phosphate. It's one of the building blocks for the energy molecule, which is assembled in the mitochondria.
Well, I'm gonna confess right here, right now, live on this podcast, but I'm the guy who doesn't talk about phosphate. But as of today, guys, we're gonna discuss phosphate in the classroom because it is the forgotten ion, right? It's something that is so significant to what we do. We always focus on, the potassium, the calcium, the sodium, but we forget about the poor little phosphate.
Right.
Well, I think that in the grand scheme of things, so we always talk about what your test wants and then what you'll actually see in real life. Your test will definitely want you to know the causes, the signs, the symptoms. They're going to be asking about magnesium, phosphate, things like that. But in real life, you simply just need to know that all of those are going to cause some sort of fatal arrhythmia. So in the lecture, if you can notice, all of the signs and symptoms that ended on fatal arrhythmia.
Yeah.
I don't care if it was high, I don't care if it was low, fatal arrhythmia. So always have that monitor on. Doesn't matter if you can't distinguish between hypercalcemia, hyperkalemia, but just have that monitor, look at your EKG, determine if it's a QT that's prolonged, or torsades, are they going into VFib, and then we can treat and address the causes once you get to the hospital.
Different roads to the same destination.
Exactly.
Absolutely.
Yeah.
Good deal. So you talked about homeostasis. When I first learned how to say that word, I wanted to use it all the time. I struggled initially. I'm like, homeostasis, that is such a cool word. But it is such a cool word, but it's such an important word to really understand. Because without homeostasis, you have nothing.
Yeah. Especially with the acid base, that is a huge topic, and I mean we don't even have enough time to discuss. But so you were asking for the EMS standpoint, what is the takeaway from all this acid base? Because literally it can go on and on and on. Med school we had weeks of lectures on just acid base, but what do you need to know in the field? One thing that I would point out is particularly with intubating these patients. So one common pitfall that I'll see is that a patient will be breathing fast. And, you're constantly thinking about the respiratory causes, but also remember in the lecture we talked about it being a compensatory mechanism. So does that patient have an underlying metabolic acidosis, and now they're trying to breathe off fast so they can breathe that CO2? If so, okay, you might decide they need airway management now. So then you intubate them, and what do? We set the rate at 12, right? Everybody breathes at 12. Well, that patient wasn't breathing at 12, so now you're having them breathe at 12, you're hypoventilating them, the CO2 is building up, they're even more acidotic because of what you did, and now they're coding, right? So it's a process. It's not so much that the intubation is tough, it's managing it afterwards. So in that case and scenario, you want to actually hyperventilate the patient. Is the one time you do want to do it, and you match their ventilation so that you're keeping that compensatory mechanism going.
Awesome. Because I'm the same way as a paramedic, I try to simplify everything. You heard the KISS system, right?
Oh, yeah.
Keep it simple, student.
That's right. Student. Okay, I heard that differently.
The word is and student, sometimes we say it's an interchangeable word.
I think it was just tailored more to me.
So, when we talk about, obviously, you talked about in your podcast about the two buffers, right? The two main systems that help maintain homeostasis. We have the respiratory and we have the renal system, right? So I tell my students, and I hope I'm not wrong when I say this, but this is an easy way for me to understand, is when I have a patient who is, let's use the example, respiratory acidotic, what would cause that? A lot of things, but what's a common simple cause that's a simple fix is an apneic or an inadequate breathing patient. If I'm not breathing off enough adequately, I'm not blowing off enough enough hydrogen, so I'm gonna become acidic at the respiratory level.
Keeping it simple, CO2 is acid.
There you go. CO2 is acid, so my CO2 levels are high. I know I'm dealing with a respiratory problem, right? I'm respiratory acidic. So what fixes that? Good ventilation, right? You blow it off. And I've seen many times in practice, whether it be in hospital or in pre-hospital, is we get a patient who's been in cardiac arrest for 10 minutes, and they're like, oh my God, he is acidic. Yes, you're right, 100%, right? But at the respiratory level, right? Because you can't go 10 minutes without breathing and not be acidic, right? Who can hold their breath for 10 minutes? So how you fix that? Ventilate. But I've seen many times people, oh my God, he's acidotic. Let's give bicarb. Bicarb works more on the metabolic, right? So when we just ventilate and we fix that respiratory problem. So to me, I think is recognizing it. And I say why we don't have to give bicarb, or why respiratory is probably more significant, because you burn more, you blow more acid, you develop more acid in the respiratory, right? And I tell students, think about it. I breathe 12 to 20 times a minute, normal person. That's how much acid you build up that you have to breathe 12 to 20 times a minute. We don't pee 12 to 20 times a minute because it takes long for acid to build up. Build up acid on that metabolic level. So why are we so quick to get bicarb? Right. So we got a patient who's probably been at this state probably for a little bit, and then as you mentioned before, we take them from one extreme to the other. So we think we're correcting it, but sometimes correcting things so quickly puts the body into a state of whoa, what just happened? And sometimes can make matters worse. So
upsets the homeostasis.
It upsets the homeostasis, and sometimes that balance, the body compensating, which we talked about last time. It's important. Never take it away, right? So if we don't pee 12 to 20 times a minute, don't worry about bicarb. Safe to say?
Yeah, well, and bicarb is one of those things that come in flavor and then it's out of flavor the next. You know, that's AHA constantly reviews that, and we're seeing that there's not so much of a place right now, usually in cardiac arrest and respiratory arrest, but there's still a place for it. So it's not completely
end-stage renal disease.
But like you said, mostly in metabolic acidosis is when we're using it, as opposed to respiratory.
Correct.
So, you know, that's the patient in renal failure. That's the patient who's been down for a very long time. The lactate is high, producing a lot of CO2. Basically from the standpoint of metabolic, not necessarily respiratory. Like you said, the treatment for respiratory, take care of the airway.
Take care of ventilation. So then it's safe to say, so we could sum this up on the respiratory and metabolic acidosis. If my CO2 has changed, most likely is respiratory, correct? Will my CO2 remain almost normal in a metabolic state, that only my pH changes?
Well, it depends on. It gets a little bit complicated because, you know, in a simple terms, if you have that bit, you are thinking that there's only one cause of the acidosis, but you can have mixed stages at times. Primary and secondary,
and then compensatory with that too. So it gets a little bit. I wouldn't simplify it too much like that. I would definitely. So in how to simplify it in the pre-hospital setting is I would look at end tidal.
Right. So we have end tidal. So if my end tidal is high, that means I have a lot of acid. A lot of acid buildup.
Right.
So
CO2 is acid.
Right. So can I say that that's probably respiratory more than metabolic?
Correct.
Right. Because we don't measure pH.
Correct. Exactly. Which is why we're all like, ABGs in the pre-hospital.
We don't do that.
But keeping it simple, end tidal is what we have in pre-hospital setting. A high end tidal generally means it's the patient's respiratory acidotic. A low end tidal usually means metabolic acidosis, and that's a little bit more complicated too. But essentially, when you see like sepsis protocols, you know, those are people who have a high lactate, who's producing a high amount of CO2, and so you're wondering, like, wait a second, why would if my CO2 is high, you guys said I'd be acidotic, why is that not a high CO2? That's because you're measuring what's being blown off, like what you're breathing, what you're exhaling. So you're not exhaling much, so that's why it's going to be low. So that's a little bit complicated.
Because it's more of a metabolic state of issue.
And so in the breathing, I believe the breathing lecture, we go over that a little bit more because that can be confusing, but end tidal is something that we value so much in pre-hospital setting.
Absolutely. I live for end tidal.
End tidal is really important, but it's also important to recognize the limitations of it, because end tidal is not a perfect correlation with the CO2 levels in the blood. As Dr. Walker mentioned, it's you're measuring the amount of CO2 that's being exhaled, and especially if you have someone with respiratory disease, lung disease, then what's being exhaled is not necessarily reflective of what's in the blood.
Right.
And it gets complicated, but you can't always look at end tidal and make it equivalent to like a PCO2, which is like, you know.
I think the best uses are really those like respiratory acidotic patients who are apneic, so like your narcotic overdoses, a high CO2 is going to equal those patients.
Right.
Someone who's COPD, they may have a high CO2 and you don't need to act on it, so I think that's important in the pre-hospital setting. And then the other extreme, very, very low, means either they're in cardiac arrest, you're not doing great CPR, and then also sepsis. So I think it's safe to like sum that up in the pre-hospital setting to make it easy.
That's a good.
There are exceptions, and it's important to understand those, especially in the pre-hospital setting, so you know the limitations of your tools as well.
So I think the caveat I got from here is the CO2 is a great measuring tool, but is not an end-all tool. It goes back to how's my patient presenting, and how am I assessing my patient, what I'm doing with that data that the patient's...
What's their past medical history that we often...
So we got to look at the big picture.
Don't
be so focused on one thing. Awesome. So, that's great information when we come to that. Another thing you talked about, when you talked about this, like, man, she hit it right on the head, is when we talk about atrophy, we talked about hypertrophy. I know me teaching, when I get into A&P and teaching, some of these words could be so complex. So how can you simplify dysplasia, all that? So I look at that, the suffix, right, prefix, I'm going back to why it was so important when we were in school and you learned about that, because I could care less until now. I realized, man, I need to go back to third grade.
Your ancient Greek was an important course not to skip out on.
Yeah, exactly. So saying, why the hell am I learning this stuff? But I like to say it's safe to say when it starts with the letter A is without or absent. When you get the dis, we're thinking difficult, right? And then the hyper, hypo, high, low, right? So when we talk about, you talked about atrophy, so if muscle's not working, it's going to shrink. And when muscle is overworking, it's going to grow, right? So I, talking to a lot of medics out there and being in education for so long, and I like to see new medics when they come out, what information they retained, and old medics, what did they do with that information, how they transformed it to something different. And hypertrophy is one, because I see a lot of times people look, LVH, cool, and go about their business. They recognize it, they can find it, but I don't think, and when I see that, I'm taking it, they don't understand the significance of what LVH can do to a human body. So I kind of relate it to something we understand it, like a bodybuilder. Nobody is born with all this muscle and looking big, right? So when they lift weights, you go heavier. When you go heavier, your body's pushing more weight than normal, right? So the muscle is going to work harder, it's going to grow. But if you look at the body, the great commercial, you ever seen the Planet Hollywood? I pick it up, I put it down. Or the other guy, bro, he's lifting and he just gets bigger.
Gets bigger.
But you notice when people get bigger, they become more rigid. They're not as flexible. They can't move as much. So I like to relate hypertrophy to that. That's the heart pumping against high pressure. It's working harder than normal, so the muscle is going to grow. So because a lot of people say, well, if it grows, the muscle's bigger. It got to be stronger.
Should be stronger.
I hope I get LVH, right?
Until you can't get in your car, you can't walk down the street.
Exactly. And when you can't function because you can't scratch your back, you're running around the shower because you can't wash it.
Exactly.
Same thing. So that left ventricle becomes so large, it becomes rigid. Is that correct? And then you start decreasing your cardiac output, and that's the big killer. And I think that's a big thing, right? With these young kids, you hear all the time, they football practice, these high school, college kids, and I always say, I tell my guys, nobody dies during football season. Everybody dies preseason. Why? Because they come into preseason unfit,
out of shape.
They're not conditioned. So now they go, 0 to 1,000, and that heart's working twice as hard as it should. They're not conditioned. Boom, they develop the LVH, right? And then they end up keeling over, and then they say, yep, this person died from an abnormal or enlarged heart. And that's the LVH that developed, right? So
the guy who used to play football or basketball back in high school and decides to pick it back up again now that he's 50.
What your mind feels is totally different than what your body feels, at that age. I agree. So I like to come up with simple things like that. The way you talked about hyperplasia, when you talked about, you used an analogy of the breast as when a female starts to lactate, how they develop more. You know, that's something I always confused when I first became paramedic. I couldn't understand the difference between hypertrophy and hyperplasia.
Yeah, because they both end up in increased size.
They're both big size. So what's the difference?
Number of cells.
The number of cells. To have an increased number of cells is hyperplasia. And so many years I struggled with that. I was like, man, I wish my A&P teacher would have just said that.
Right, that one thing.
That one thing, you know? So, awesome. So, hypertonic, hypotonic, you talked about that. That's something I confused for many years. You know why? When you think of hypo, you think of what? Low. And now we're talking tonic, right? So we're talking in cell, out cell. So does the fluid come in and the cell becomes hypotonic or hypo?
Yeah.
So what are we using as a point of reference? The fluid that's in the cell or the fluid that's out the cell? So if it pulls the fluid out, that's what we should reference, or do we push the fluid in? So I know a lot of students struggle with that. So when we say hypertonic state, what are we referencing?
So you always have to look at the question stem. It's going to say, what is the tonicity in relation to blank? Because you can't just, I mean, it has to be in relation to something. It has to say, what is the cell's tonicity? It has to say, what is that interstitial space? It has to say, what is the intravascular? So if you get that answer wrong, it's because you didn't separate those spaces. So remember, we have intracellular and extracellular. And of the extracellular, you have the intravascular space and the interstitial space. So it always is going to tell you what is this in relation to this. It can't just say what is the tonicity of the cell. It's not a fair question.
Right.
So I think the simplest way to like memorize it and kind of grasp it is looking at that podcast, and tonicity, anything that says tonicity is referring to the solute. So don't be confused. Again, you can say, okay, water goes from a higher amount of water to a smaller amount, but the tonicity is the opposite. So it goes from a lower concentration to a higher concentration. Concentration is the solute, not the water. So if you keep that, you have to get the basics first, or you're gonna mess up all these questions. Like if you
and that's a common thing I see when my students test. They confuse it. You know? One, they stressed out. They take a test. So are we talking about the salt? Are we talking about the water? What are we talking about? So,
concentration is always the solute. Go from that first.
So that's solute. That's salt. What's the salt do? Water follows it. So if the salt is higher in the cell, then it's a no-brainer, right? Fluid's coming in. If it's the other way around, then it's going to follow where the concentration is higher. Right?
And in the grand scheme of things, again, that's test purposes. What this really is for in the practical setting is what type of fluid are you using to replenish that patient? Are we using a hypertonic saline solution? Are we using normal saline, lactate ringers? That's all this is about. And it's also to help you understand edema and like where that comes from and why we have that. Outside of that, it's just for the test, right?
So what brings me to another thing. When you were lecturing, I was listening to your podcast. You got into all those electrolytes, you know, the ions, you know, what's positive, what's negative, and where is it at? Like sodium is a big one, you know. Sodium is obviously outside the cell, right? Extracellular potassium is in the cell. You know, I remember that. Circle K.
Circle K?
K is inside. Right?
That's true, right? Circle K, right? Right. Now that's how I'm going to remember it.
So it's always saying, is sodium in the cells? Is it potassium? Circle K is in the cell. Another way I remember numbers, because unfortunately, when I teach some people, they forget. And even somebody like my age, I need shortcuts because I don't have a lot of memory left in my head. So it's mostly my hard drive is full and is antiquated. But numbers, right? Easy way I see it, I was talking to Dr. Roca about it, is if the number is a big number, that's out of cell, extracellular. Small numbers, intracell, right? So now if I know that potassium, 3.5 to 5, that's a low number. If it's a low number, it's in cell, intracellular. Sodium is a higher number, right? 100, 20, 35, 45, high number. So I know that's extracellular. So if I look and if I have a piece of paper that says this is normal range and it has these high numbers, I already know that's extracellular ions. Small
the cell is only so big. You can only
so it keeps
small numbers in there.
So is that an easy way? Does that make sense?
You should have taught my med school class.
Might trick you up with bicarb though.
Bicarb.
It's kind of a middle number, 35 to 45, and it's kind of.
Do we look at bicarb? But 35, 45 was still, I still consider.
I would still consider it like a.
Well, you can say say 7.34, and
That's
you can do the
pH,
7,
right?
the pH.
Yeah,
Yeah, maybe you can memorize the opposite, maybe.
Yeah.
Right. So
Yeah.
those are some
We're not
things
confusing
that.
people now.
Another thing I want to talk about, because we talked about electrolytes, is that calcium one.
Right.
I was confused quite a bit on it because I'll read something, but then I'll see a doctor do something different. For
Really?
instance.
Where does that happen? That never happens.
I know. I was like, oh my
Don't
God.
they know everything?
That's like the
Okay.
Tooth Fairy. I found out it wasn't real. Like, oh my God, serious? So, like with calcium, and correct me if I'm wrong, a heart that's beating and functionable, the calcium helps with the contractility, right?
Right.
So I'm trying to grasp and understand why we give calcium, not routinely. If I'm hypokalemic or hypocalcemic, I understand we give it.
Yeah.
But why would I give that in cardiac arrest? The heart, I understand we want to increase contractility, but if a heart that's not beating, how does that function happen?
So do we give it in cardiac arrest all the time?
No.
No, right? There's certain indications. So what we're treating in the hospital and what you're treating in pre-hospital when you give calcium is you're treating hyperkalemia. So remember in the podcast where we talked about renal failure patients or, just patients in general who for some reason have hyperkalemia, their cardiac membrane is not stabilized because you remember you have that sodium-potassium pump. Calcium is actually on that pump too. It's the forgotten ion that's on that pump. I don't know why they don't call it the sodium, potassium, calcium pump.
It's too long.
But that's where all of that comes from. So it helps with energy there. So when you have a patient who is in cardiac arrest from what we presume is hyperkalemia, those are the patients that you're treating. Similar to metabolic acidosis. Hyperkalemia is associated with metabolic acidosis. So in acidotic patients, we'll sometimes treat with calcium too to stabilize that cardiac membrane.
Awesome.
So we're only using it for certain indications there.
So you mentioned now we got to that hyperkalemic patient. If you could explain, because I know students are going to look at that podcast and be like, I think Dr. Walker made an error there. Did she say we give albuterol? So if you don't mind
We're not talking
explaining.
about respiratory system.
Yeah, this is hyperkalemia. Is that
Why
metabolic?
albuterol?
Why is we giving albuterol? I didn't hear wheezing. How did that dead patient wheeze? I didn't hear it. So, and that's a key point. We understand why we give potassium.
Yeah.
We understand, maybe we can explain it too. I think most medics will understand why we give insulin as well. But maybe you explain why insulin and why albuterol is given in the hyperkalemic patient.
Yeah, both of those they have similar mechanisms. So both actually are used to push the potassium that's in the intravascular space into the cell. So it's just temporary. It's just a temporary function. So generally it lasts like around 2 to 4 hours. So, enough for transport. But then likely we'll have to redose if they're going to be in the emergency department for a while. So both of those, insulin and albuterol, simply push the potassium in the cell. And then in the hospital, you still need something to actually excrete that potassium. So we'll use like K-exolate sometimes, which is often controversial, but dialysis may be the end result, the only way to kind of get off that excess amount of potassium.
So hyperkalemic patient, safe to say, let's get the potassium back home in the cell.
Right.
Yeah.
Circle of K.
The circle
Yeah, the
K,
circle
right?
of K.
That goes.
So,
And it's a great illustration of how no drug does just one thing.
right.
Yeah.
Like
Absolutely.
never, which
Yeah.
is why we learn about side effects and all of that.
Right.
Well, albuterol, one of the side effects is pushing potassium into the cell,
i.e. hypokalemia. Yeah.
Perfect. That's a great.
or
great-
causing hypokalemia,
Yeah,
potentially.
right.
So good. So a
Right.
patient has a potassium problem. We need to be able to.
concerned about
what's the
how-
what's the
right.
significance of that though? Now that we mentioned that, if I'm having an asthma attack, because now we got
Right.
to balance both, right?
If you already have low potassium and then you get albuterol, you could go into cardiac arrhythmia from your now worsening
And
hypokalemia.
it's not necessarily the beta 1 effect. It could be because
Yeah.
of the potassium
Right.
effect. So something to pay
Yeah.
attention to. Very good. Is there an alternative we could give? Would Zopanex have the same concept or no?
We give Zopanex mostly to combat that tachycardia part of it. It's not one that we would typically use in the treatment of this, and it's expensive too. So we have to always have clearance. But I'm not sure. I don't know if that works in the same pathway or not.
Okay.
But usually when we use Zopanex, it's just because the patient gets very tachycardic.
Long term, I tell my guys too, don't get hung up in our realm of practice, like, oh my God, this guy right here who's 21 years old,
Thank you. Yeah.
who's having an asthma attack, slightly tachycardic, 110 maybe. I'm not going to withhold Peter, I'll give it to him. I'm not worried about the short term. But if I had this guy who had a respiratory infection and he has to be tackled with antibiotics, so we might prescribe him maybe more Zopanex because he has to do it every 4 to 6 hours at home for 2 or 3 days.
Yeah.
So I tell him in our realm of practice, in our setting, which is very short.
Yeah. It's not anything
Don't
to
get hung up.
consider. Yeah,
Don't get hung up.
Yeah.
Don't be like, oh my God, I'm a whole. Because I remember them talking about Zopanex is best for no tachycardia, and I'm worried. I was like, don't give the Buterol.
Yeah.
But take him to the hospital.
Right, exactly. Don't get a refusal.
Scotty Beamus, Scotty Beamus, they probably know who Scotty is, but take us to the hospital. So, and we talked about the phosphate, which was cool. Magnesium is an interesting electrolyte, I think, because I think, at least I do, there's not a lot of literature that I could find that really says, how does magnesium, when we give it, really work, and what does it truly do at the cellular level?
It's kind of the most mysterious electrolyte.
Yeah, for magnesium.
Yeah.
Right.
Yeah.
I'm thinking about
but we know it works. It does things.
Pregnancy as
Yeah.
well, complications.
Because it stabilizes the cell membrane, right?
Right.
So that's what we know, but the functionality behind it is the mysterious part, right?
Yeah.
It's kind of like, I don't know if you saw the show Martin Lawrence. You know, his best friend Tommy, he had a job, but nobody knew
Nobody knew.
Nobody knew what it was, right?
You know, he
Yeah,
works,
it's
but
kinda
what
like-
tell me you work. You know, it's like that, you know?
Yeah.
So that's the
Right.
magnesium,
Yeah.
right? We know he got a job, we just don't know what he does.
The only time I really have seen us use that in the pre-hospital setting is pre-eclampsia.
Right.
So I'm trying to think. I don't think we use it for
asthma.
anything. Well, yeah,
Just full
you're
muscle
right.
relaxation
Yeah.
and
That
pre-hospital,
is something we're doing a lot
yeah.
more.
Yeah.
If they have pretty bad asthma attacks, it decreases ICU stays, so we'll do that in the pre-hospital.
I'm huge on magnesium and asthmatic. I come from a background in New York City, where Doc
Yes,
you're familiar
yeah,
with, where they probably got more asthmatics in the zip code than some states. You know, where actually, the EMTs in New York City give a butyral Atrovent. It's a BLS drug.
Yeah.
But we could never get orders for epi because they always worry about the tachycardia. But
Yeah.
their docs were so quick to give mag, so we always gave mag. But I've seen it work so well.
Yeah.
The biggest hiccup I get from my students to become believers that it works is, well, if I got to run over 10 minutes, that means it starts working in 10 minutes. I know it starts working when it's a system, right?
Yeah.
We don't run it over 10 minutes for therapeutic effects.
Right.
We do it so we can minimize the side
The
effects.
arrhythmias and exactly, respiratory depression.
Yeah, I had a coworker who I did a class, talked about it, run over 10 minutes and stuff, and he thought he could put it in a syringe, 2 grams and and a couple of cc's of saline, and could push over 10 minutes. He says, man, what my patient did, he goes, I had a pucker factor. I thought I was going to kill my patient. I would never do that again. I should listen to you.
Yeah,
So if I said, if you give it less than 10 minutes, you will see every side effect.
Yeah,
Right.
yeah,
You know,
exactly.
so stay away from that. So easy way to remember. I don't know if you guys do this because I always have questions how I run mag. If I don't know how to run it, I'm not going to give it. You know, so we use a 100 bag. I like a 50 bag. Why? Because 50 is closer to 60, and you understand why in a minute. So I get a 50 bag. I put the 2 grams in it. I use a 10 drip set. A macro. Why? Because I'm running over 10 minutes.
Right.
So the 10s cancel out. So your drip rate is your IV bag.
Nice.
Oh, I like it.
Nice.
So if you use a 50
Yeah.
bag, 50 drops a
Bag.
minute.
Nice.
If you use a 100 bag, 100 drops a
Takes
minute.
the math
out of it. I'm all about take the math out, you know?
Nice. Yeah.
I was never good at math, so
Yeah.
I try to teach my medics that. So simplify, right? KISS, right? Keep it
That's
simple,
right.
student.
That's right.
All right. So we talked about acid base, which was pretty good. So I think that sums up your lecture there. Unless anybody docs, you heard her lecture, it was fantastic.
Yeah, no, it's
anything you guys want
pretty
to add?
basic. It's going to be a lot of memorization, unfortunately, for that type of lecture that we did, the cellular part. But after that, it gets more fun, and you get to see more of the practical side.
Yeah. So,
The other thing I mentioned, it was a great lecture. When you're reviewing it and reviewing that chapter and that material, don't be afraid of that buffer system equation. I think if you understand that equation, it actually,
That's a good point.
you'll understand all of it.
Yeah.
Think about where the CO2 is going. CO2 is being exhaled from the lung. When you lose CO2, what happens to that equation? And vice versa. If you understand that equation, like acid-base makes sense.
Yeah.
And how that equation fits into both the respiratory system and the renal
Yeah.
system.
Right.
Understand how that That equation bridges those two organ systems. If you understand that, it makes sense.
Yeah, and this is
Don't
like
be afraid of it.
this is a very foundation, right? And you have to get your
Yes.
foundations
Yeah.
very, very
Yeah.
strong, because you'll be building on this not only throughout your paramedic
Yes.
career, but throughout your entire life.
Yeah.
When you're understanding things, at the end of the day, it'll boil down to this lecture. Because everything,
that's true.
at the end of the day, whatever happens, whatever fancy drugs there are, whatever is going on, at the end of the day, it boils down to this. So just spend some time in this lecture,
Yeah.
and I think it'll make you a good paramedic student, a good clinician,
Yeah.
and help you save lives later on.
And Dr. Roque is saying that Dr. Walker's cellular metabolism lecture is life-changing.
And I did not think so, but now I am just,
Life-changing,
yeah. I'm
It's to
flattered
die
now.
for. It's to die for. It's so funny. I want to end it with this, but I tell my kids were little, they know now. They figured it out. But I should tell them, because my kids think I'm a dinosaur and I'm an antique, and they can sell me. And I should walk around with a name chain that says antique.
Right.
But we go swimming in the pool, and I'll tell my kids, this is how I got away for many years not giving them their allowance. I'll be like, I bet you your allowance, Dad can swim an Olympic-sized pool from one side to the other side without coming up for air. They was like, no way, Dad, you can't do it. You're too old.
Right.
But you know what I used to do?
Bring a snorkel.
No, bring a snorkel. I didn't think about that. Instead, what I did was I actually hypoventilated till I was almost dizzy. I figured I'd blow off all my CO2.
Right.
I'll stay underwater.
So your
and the
brain
time my
can
CO2 levels increase, that
That's right.
stimulates my chem receptors to tell my diaphragm to breathe. I'm back on the other
You're
side.
back on the other side. You're good.
I'm going to have to pay my kids lunch money.
Not
It was
recommending
awesome.
this for you.
I recommend the snorkel.
Snorkel's a good one. I didn't think about it, I am still in the water, right?
That's right.
So let's shift gears here, and I want to get into Dr. Roca's PowerPoint podcast on shock, which was very, very good, and
Also a life-changing lecture.
also life-changing.
Absolutely.
And that's probably a lecture, and that's probably information. As you mentioned, the last podcast we did is don't shortcut things, right?
Yeah.
This is one we don't ever want to shortcut. If you shortcut shock, the patient's in trouble.
Yeah.
Patient's in trouble. So we talked about, you talked about some key things like the anatomy, physiology, which was good. You talked about cardiac output, stroke volume. I don't want to beat that up
keeps
too
coming
much
back.
because we just talked about your last podcast, but you see how, that's what I wanted to talk, how it keeps coming back. And that's something we will visit all the time. That is the formula of life. Cardiac output times PVR equals your blood pressure. Without blood pressure, we have nothing. We have a dead patient.
Yeah.
So, and let's relate that formula into a cardiac arrest person, right? So what's cardiac output? That's CPR. Cardiac output.
Right.
What's PVR? Epi.
Yep.
Right.
So if I do great CPR, I give epi every 3 to 5, I should have what? Blood pressure. And if you have viable organs, they should be perfused.
Yeah.
Right.
Yeah.
Right.
It's that simple.
That's why CPR is the only thing that we found that
Right.
actually works, because your body's already releasing the epi, so the extra epi we're given may or may not help. We still do it now because there's still a little bit of evidence, but CPR hands down is exactly what you need to maintain that cardiac output.
Absolutely. So, and I found that interesting. You talked about that formula in your podcast, which is I kind of beat my students up. So thank you for. I got somebody who
Like
reinforced.
Dr. Roque.
Dr.
Yeah.
Roca here is reinforcing what I'm
I
talking about.
promise you,
guys.
every lecture of mine, I will start off with that formula. How about that?
Thank you so much. Thank you so
Even in your
much.
OB lecture.
Even your OB lecture,
Yeah.
pediatrics, geriatric, like everything.
That's very
it's
relevant to the
perfusion.
breaking patient.
Exactly.
It is actually.
Yeah, it actually is. I know we'll talk about that when we
Oh,
get there.
Lord,
But
you got
him on
that.
don't get me started. All right, no, I'm not going to go there. But 3 main things that we talked about that I love the way you presented it, which was the heart being the pump, the blood being the fluid,
Yeah.
and the vessels being the pipes.
Yeah.
Yep.
It's that
Right.
simple.
Yep.
Absolutely.
So if you have no pump, no circulation. You have no pipes to take it from point A to point B, no
And
circulation.
you need to find out what's wrong, which of those are the fault.
Right.
And that's how he went into it. Like, if it's the issue with the actual pump, then that points you to a certain type of shock. If there's an issue with, like, the fluid in the pump, that points you to.
Right.
So, again, if you understand that equation and you kind of break things down, make them very simple, you'll be able to understand.
I agree 100% because I've seen it out there with providers is I got a patient who's hypotensive, and what we want to default to, hypovolemia.
Yeah.
Yeah.
We want to default to that, but his heart rate is 30.
Right.
So that's
Right.
not a fluid problem, that's a pump problem. Fix the
We
pump.
were involved in a little bit of situation like that a couple weeks ago, where again, you think hypotensive, first thing fluids. We had a patient came in via EMS. He was given I think maybe a liter of fluids because he was 60/40. That was his blood pressure. So when he came in, me and Dr. Benzing were managing him together, thinking, okay, once again, it's always fluids. Let's give him fluids. But we were both cautious for this particular patient and say, you know what, let's just start with like a 500 cc bolus, see how he responds. And so at that time, they got an x-ray. The x-ray was clear, didn't show fluid or anything like that. But when we listened, he had crackles. So again, with that assessment, we were like, wait a second, he has pulmonary edema. So how is he, we're just thinking is he really hypovolemic? What's happening here? So we put an ultrasound on him and we saw that his heart was not pumping. Yeah, it wasn't pumping very well. Now you may say, I may not have ultrasound in the pre-hospital setting, but you can see what that fluid bolus does. It didn't do anything. His pressure stayed 70s/40s. So we're like, okay, it's not a problem with him being hypovolemic. We're looking at this cardiac output or his pump essentially on the ultrasound. We think now he's in cardiogenic shock. And that's a hard diagnosis to make. Even with those tools, we still were like, should I, should not? Yeah, we were going back and forth. So, you did the cardiovascular lecture. Now we're starting to talk about dopamine. We're talking about is norepi appropriate? Is dobutamine appropriate? We're having to figure out what should we use for him. I think we decided to go with dobutamine. Which actually did exactly what you talked about. It caused the side effect of vasodilation, and guess what? His blood pressure dropped. So we're like, okay, well, we were wrong on that one.
Then we started Levofed.
Yeah, so then we started Levofed, which is actually the more appropriate drug to start because again, increasing that PVR. So we wanted to increase the... Yeah, exactly. So, we're thinking through all this. See, we have to go back to our pathophys. And
so we tightened the pipes.
Yeah, we tightened the pipes, and he actually did well from that. We got cardiology involved. They did their stat echo, and they actually, so his blood pressure did okay for us in the ER, but when he went to the ICU, it actually was still hanging around 80s and 90s. So they added phenylephrine. And I think you mentioned that as well, that tightens the pipes even more. So this is a case where, it's taken us an hour or so to figure out in the ER. You have 15 minutes maybe in the pre-hospital setting. You don't have much time.
With less diagnostic tools.
Exactly.
Which is partly why I don't think it's wrong. You don't want to overdo it, but to put something in the tank. Because it's a pump, it's a tank, or it's the pipes. EMS pre-hospital, one of the first things that you can do is make sure it's not the tank.
Right.
And by giving, and you don't have to give a full liter.
No.
Like we did. You start with just a 500 cc bolus. See how they respond. If they get better, then the tank's at least part of the problem.
Right. So it's safe to say that, and that's a great case, man. I'm glad you guys mentioned this to our audience here. So is it safe to say, assess those lungs? Constantly.
If
I have rails, if I hit any kind of rails, let me hold off on the fluid. Maybe it's not so much a fluid thing, because even if it could be, let's say, a fluke. The crows are flying over us, and this is a fluke. All in all, that pump can't pump. So no matter how much fluid you add, it's not going nowhere.
Listen to the lungs before you give fluid. Listen to the lungs after you give fluid. All the time.
Great example, because flash edema could also be an issue. So if you have fluid in the lungs, maybe I hold off. Now if the lungs are clear, give that fluid challenge and see if anything changes. Good. And that's something I promote here, so I'm glad I'm teaching them the right thing. And we're going to emphasize that's a great case study that took place.
We don't get it often in the ER, so we had to kind of combine minds and say, okay, we got these 3 drugs, which should we give, what should we start? And we just kind of played it by ear and see how does he respond to this, So.
Just from my mind, is there any contraindication to mixing those two?
Mixing what?
The dobutamine and the levo?
No, actually, that is something that you can do. And we ended up doing dobutamine and Levofed.
Yeah, we started with dobutamine.
We turned dobutamine off for a second when the pressure, got really low because of the dobutamine, but then turned it back on because we knew he still needed something to pump, and then added the norepi to that. And then ICU then turned and added phenylephrine on top of that, so he ended up being on 3 pressors.
Oh, awesome. Interesting. Great case, man. Another thing that you talked about, Dr. Roca, is, and I'm going to bring this, I'm just trying to bring up where that slide is. It was freaking awesome when you talked about the different classes, I should say, of shock. And I know you talked about 1, 2, 3, 4.
Yeah.
So obviously in the pre-hospital arena, we have no measurable outcomes of how to say 1, 2, 3, right? Using diagnostics. And one thing I really deter from teaching my paramedics is determine that this is 1,000 cc's, 15 you can't.
Yeah.
And I've proven that here. And guys like, yeah, I know the difference. I've gone outside, make fake blood, put
You
a
can't.
cup,
Yeah.
pour it down.
Yeah.
People say it's 1,000, 200.
Yeah.
I mean, it's so vague. It's really hard.
Yeah.
So, but one thing to me that's very objective, or that helps me, is mental status and heart rate.
Yep.
So when we have a heart rate below 100, I know that's class 1
Yeah.
Right.
because I'm sitting normal. I lost
You're not
blood.
compensating.
I lost
Right.
blood,
Yeah.
but I didn't lose enough
No.
blood
Right.
to kick in the body's
Right.
compensating factors, right?
Now, question for you: is that patient not in shock?
No, he is.
Exactly. But
Yeah, it's
so
great.
some people will look and
Yes,
say,
good
"Oh, they're
point.
not tachycardic. They're not in shock."
And
Yeah.
that's why mechanism of injury is so, or nature of illness is so important, because that's going to stimulate your high index of suspicion.
Right. Absolutely.
And
Yeah.
that together all comes, it should come all together and say, okay, this is a sick patient.
Yeah.
Right.
How sick is he?
Right.
What's my heart rate? It's good. Mental status, normal. Respiratory, normal. Those are things that are pretty objective.
Yeah.
And they can't
And
trick
things you
you.
can reassess. So right now you're in shock still, but you're not compensating.
Correct.
How are you going to be 15 minutes from now? So that's why
Right.
our blood pressure, you reassessing the heart rate, the mental status. It's a constant reassessment throughout your
Right. And
ride.
then I go to, if my heart rate's between 100 and 120, I know I'm a class 2. Now what's happening? The body's starting to compensate. So I use not so much, what it is liters, right? mLs. So I use mLs. I use a liter of soda. So if you lost 1 liter,
Right.
less than 1 liter, where we at? That's class
Right.
1.
Yeah.
If I lose 1.5 liters, right? Now I'm a class 2. Now we at a level where, okay, the body recognizes, whoa, there's a problem,
Yeah.
but don't worry, I could compensate.
Right.
And
right.
now I'm between the heart rate 120, right? And my mental status is still good. Why? Could compensate. So now 1 and 2 are my reversible shocks. Still shock,
Yeah.
but it's
Yeah.
reversible.
Right.
If
Right.
and if it's hemorrhagic, it's real easy. First thing you should do is stop the bleeding.
Right.
It makes all the sense in the world, right?
Right.
Next is the class 3 shock, which now is decompensating. So now I'm lost 2,000 mLs or 2 liters, right? When I lose 2 liters, I'm now going to be above 120.
Right.
Yep.
My heart rate above 120. Now this is the deciding factor. That I went from compensating. Now it starts to affect my mental status. Now I become lethargic.
Right.
My mental status is slightly altered.
Yeah.
Yeah.
So slightly altered mental status, heart rate above 120. I'm class 3. Now we have a more serious patient.
Right.
Class 4, and I always add this to my slide when I teach this, especially in tactical medicine. Class 1, am I going to die? No. Class 2, am I going to die? No. Class
But
3.
did you die?
Class 3, I'm going to die?
Getting there.
Probably. Maybe. I put maybe.
Right,
I put maybe.
right.
Maybe. All depends on how you
You're getting
recognize
close to the edge. Yeah.
Maybe.
Right.
But you recognize, how do I know I lost 2,000 mLs or 2 liters?
Yeah.
Because I have an altered mental status and a heart rate above 120. So I already know
Right.
that blood on the floor is significant.
Right.
I don't need to
Right.
calculate it. I
Yeah.
know that's 2,000.
Absolutely.
Now, when I lose 2,500, I'm unresponsive.
Yeah, that's
With a
having your
heart
blood
rate of
volume.
140.
Right.
Now, if I have an unresponsive patient with that mechanism of injury, the heart rate 140, is he going to die? Probably.
And also the quantity is really just a guideline anyways.
It is.
I mean, different people have different blood volumes.
Right.
We're not all the same, you know.
Think about pregnancy people, right?
Yeah.
Pregnancy, also
Pregnancy people.
pregnancy people. I mean, whether it's pregnancy, even just the size of the person.
Right.
Yeah.
Yeah, absolutely.
You know, someone who's 300 pounds is going to have a larger blood volume than somebody, you know, who's 100 pounds. You know.
Yeah, so that was great. I'm glad you talked about that, because that's important. So guys, when you see that part of that podcast, please, if you already saw it and watching this, go back and watch it again.
Yeah.
Very important. And so in a nutshell, if it's not if it's a distributive shock, we're not going to fill the tank that we have the vessels filled enough that
Yeah,
now
right.
we were good. No,
Yeah.
we're going to
Right.
constrict,
You wanna
vasoconstrict,
know. Yeah,
right?
exactly.
Because I have people do all the time. Oh, it's hypotensive. Give them fluid. And I will say though, and I do teach my students this, that in a distributive type shock, guys, that's a shock where your vessels are completely dilated. When vessels are completely dilated, they become leaky.
Right, right.
So we could fix with vasoconstriction, and then we're still questioning why they still slightly hypotensive.
Yeah.
Fluid.
Yeah, exactly.
Once again, go back to
It's
why.
the easiest
What's my
start.
lung sounds?
Right.
Yeah.
Right.
What's my lung sounds? Then we
Yeah.
some fluid. So I thought it was a great presentation. You
absolutely.
cover those things. It's real easy to distinguish if it's a hypovolemic type of shock, whether it be hemorrhagic or metabolic, whether excessive urination, diarrhea, breathing, all that good stuff. That's still a hypovolemic type shock. We know we fix that with fluid. If it's a pump problem, cardiogenic, we fix that with
Medication.
inotropics, some inotropic type drugs. If it's a distributive type shocks, let's constrict those vessels back down
Right.
and stop the agent that's creating that if we
Right.
can.
Yeah.
You know?
Yeah. Absolutely.
So, I mean, great presentation. I appreciate you
good.
taking the time, coming back out again and doing this. And you guys have anything you want to add to that?
No, I think definitely. I love these two lectures because it's the premise and foundation for them all. So, yep.
Yeah, Dr. Roga said it. I could have said it better. This is your foundation. So if your foundation is rocky, what you build might collapse.
Yep.
So if you have a strong foundation, you could build an empire.
Exactly.
Yeah.
I mean, in Dubai, they're building castles in sands, because they have good
That's right.
foundation.
Good foundation.
Yeah, right.
Good
That's
point.
what
Good point.
By the way, I was very lost during this lecture with all these Hollywood references you guys were making.
Like Scotty?
Yeah, Scotty and
Scotty,
Danny
Star
DeVito's
Trek.
friend.
Star Trek was
Martin
the guy.
Lawrence
Yeah,
and
Martin Lawrence.
yeah,
Had some catching up to.
yeah, exactly. But otherwise, a good lecture. Yeah.
Well, maybe we'll subscribe to Netflix for you.
Okay. All right.
Catch up, maybe TV Land or something.
Yeah.
That's what you need more of in residency is more TV.
What is banana? I need to see all this whole.
Well, once again, thank you guys for coming out to
Thank you for
OMI and
having
doing
us,
this.
yeah.
Well, that wraps up our discussion here on the two podcasts that you might have seen already. Once again, if you have any questions for our docs here on this panel, feel free to email me at fmarquez@omi.edu, and I'll make sure I'll forward these questions to docs and get you guys some answers. I hope you enjoyed this presentation. See you guys on the next one.
Thank you.
Thanks.